Hi, my name is Ashley Fisher, and I will be going over a critique on the risk of mortality in patients infected with SARS-CoV-2 variant of concern, match cohort study from the British Medical Journal. For some context, in fall 2020, a new variant of SARS-CoV-2 was on the rise in the United Kingdom, which was identified by the Public Health England in December 2020. The new variant was spreading at a rapid rate, causing an increase in hospitalizations, lockdowns, control measures, and travel restrictions. The researchers wanted to investigate this because there had not been unbiased estimates of the mortality from this variant in previous research. The main objective was to investigate if there is a change in mortality from the new variant of SARS-CoV-2 compared to the previous ones. The primary exposure was positive SARS-CoV-2 test results at one of the community centers between that time period. They utilized a thermo-TAC-path multiplex PCR to get these results. For the outcome, it was a death of participant within 28 days of the first positive test result. These participants were followed up for 28 days for the most part, except for 15% of the sample was only followed up for 14 days due to the study coming to an end. They also looked at death certificates listing COVID-19 on them as part of the outcome. The study design was a matched cohort study, which is a study that pairs unexposed and exposed participants to minimize bias and confounding factors in order to investigate the change in mortality behind the new variation of SARS-CoV-2. The matching criteria was age, data specimen collection, sex, ethnicity, location, and index of multiple deprivation. After account for these factors and elimination of other factors, the study population was nearly 110,000 participants, which left us almost 55,000 matched pairs. Using the Cox proportional hazards model, a mortality hazard ratio was calculated between the spike protein genes that were positive versus the spike protein genes that were negative. The Cox model, however, was violated due to a divergence between the participants after 14 days. The stability of this study was 95% confidence. The researchers used linked data from syndromic community testing and death certificates to determine if the new SARS-CoV-2 variant had a different mortality risk than others. The mortality hazard ratio of the new variant was 1.64. These results indicate an increase in deaths from 2.5 to 4.1 per 1,000 cases. The total number of deaths within our sample was 368, with 227 of them coming from negative spike protein genes. So there's actually a hazard ratio of 1.37 for negative spike protein genes. The researchers were very upfront about a selection bias coming from the contact tracing and community testing centers, since those are largely self-selected. They did mention that they only accepted results from Lighthouse Laboratories, so they started with about 940,000 participants and ended up with about 109,000. But due to that large sample size, it does help to eliminate some of the bias. They also mentioned a potential bias that there was a higher percentage of infections without symptoms from the spike protein gene negative group. For critique of the analysis, the researchers did a very good job at matching, and they controlled for many confounding factors through this process. The main difference that they wanted to look at was the spike protein gene using the TAC-path assay. The researchers did acknowledge at the time that hospitals were under strain due to the rise in cases, so they accounted for systematic bias by matching participants. I was very impressed by this. As I mentioned before, there was selection bias, so these results are not generalizable to the elderly or those under the age of 30. They also didn't account for comorbidities or vaccinations at that time. And there was only a short follow-up, so this doesn't really show you long-term effects. And I also wanted to mention that there could be information bias with false test results or user error with the TAC-path assay. So those are just things to keep in mind. In conclusion, the new SARS-CoV-2 variant has a higher mortality rate, thus meaning it is more lethal, which confirms the government's actions into reducing death and implementing control measurements. Thank you for your time. Any questions?